This presentation will be about belly aching in Oz, and so we will talk about peptic ulcer disease and GERD, and we will talk about constipation and diarrhea and all that there is to do with poop and pee. Well, I guess not pee so much, although we will talk about stones a little bit in terms of vitamins and minerals, and so let's get going. In Chapter 50, this is a little bit on the patho of hydrochloric acid with the acid-controlling drugs. That is really what is causing the problem. There is what we found for years is that we thought that ulcers were caused by stress, but that is actually not the main cause. It is the ACH, histamine, and gastrin that we have to target for medication therapy, because there is a likelihood that 90% of the patients with duodenal ulcers and 70% with gastric ulcers could be infected by something called Helicobacter pylori, which leads to ulcer formation in 40 to 60% of patients older than 60. Now, only 10% of those in the 30 to 40 year range have this. But when we go for tests like an EGD in the GI lab, we are looking to see if they have this, because later in life, if H. pylori goes untreated, it can lead to stomach cancer. And so we want that stomach pH range to be in the 1 to 4 acidity level, and because that's part of the body's defense. And so if it's not, we can get peptic ulcer disease, or we can have gastric reflux. And so that's how we have to use these medicines to treat that. So the first thing that came around to treat the acid was antacids, and they were the very first thing that was introduced. And antacids neutralize the acid. That is their action. Plop, plop, fizz, fizz. Oh, what a relief it is. That was the very first antacids. And Tums is another antacid, and people would chew them up like they were candy, and they would get stones from having too much calcium, or they would have other problems. People with renal disease cannot take them because they're getting way too much calcium, so that became problematic. But that was the introduction of H2 receptor antagonist as well. That is not what Tums are. We'll talk about those separately. But antacids are things like Tums, and those are over the counter. They're an antacid salt. Simethicone is something that we give to babies for gas or flatulence, and it reduces bloating. Antacids neutralize acid, and then they also stimulate the secretion of mucus and prostaglandins and bicarb from the cells, and mucus helps protect the barrier against hydrochloric acid. And of course, antacids are indicated for acute relief of symptoms with peptic ulcers, gastritis, gastric hyperacidity, and heartburn. Some common ones that you can think of might be Mylanta. Oh, Mylanta. That's one that we would tell patients to take 4 times a day because it's in liquid form, and it would help to neutralize the acid. All of these treatments require non-drug treatment. So they will tell people that they must lose weight. If you're obese, it puts you at a greater risk for having gastric esophageal reflux disease, or GERD. So we will also tell patients to elevate the head of bed at least 45 degrees. They used to have these kind of crazy questions on NCLEX, and the answer was to put a brick back behind the head of the bed, if you were in a home health situation. Now we have specialized pillows and things like that that help to elevate the head of the bed. Carbonated beverages, of course, I've always said don't drink, don't smoke. High fatty foods like McDonald's, those are shown to increase GERD, but there are new studies showing that if you just quit that alone, that doesn't lead to significant improvement, and we have to also use some kind of drug in combination with this, but they need to do that too. So, the H2 receptor antagonists are known as the tadines. So maybe you've heard of cimetidine. That's Tagamet. They help to reduce, but not completely abolish acid secretion, excuse me. So antacids are neutralizing it. H2 receptors, antagonists, reduce acids. So they're your acid reducers. They've become really popular. They're over the counter. We've got cimetidine, which is Tagamet. We've got ranitidine, which is Zantac. We've got famotidine, which is Pepcid. And then I'd have to look up the nizatidine. But H2 receptor antagonists block H2 receptors at the parietal cells, and this makes the histamine stimulation of ACH and gastrin less responsive. So they have several uses in the treatment of GERD, peptic ulcer disease, people who have erosive esophagitis, and it's an adjunct therapy to help upper GI bleeding and to treat pathologic gastric hypersecretor if people are having too much acid, like in Zollinger-Ellison syndrome. Now, this is good to note. Tagamet or cimetidine is actually on the Beers list for older adults because it can cause confusion. So we don't like to give that one to older adults. PPIs are a newer drug, and so prazole is the suffix for this one. Lanprazole, known as Prevacid, omeprazole, known as Prilosec, rabeprazole, Acifex, pantoprazole, known as Protonix, and asomeprazole, known as Nexium. They are more powerful than the H2 receptor antagonists because they bind to the hydrogen potassium ATP pump, and that helps them inhibit the action of the enzyme, so they block 90% of acid secretion over 24 hours. So this makes them much more powerful. Out of all of the medications that we're using for PUD and GERD, they are more powerful, and food absorption is not affected. So they are currently indicated as the first-line therapy for erosive esophagitis, symptomatic GERD that isn't responding to other treatments with the H2 receptor antagonist, and short-term treatment of duodenal ulcers and active benign gastric ulcers. They also help to treat with NSAID-induced ulcers, which, if it is not being caused from H. pylori, that is the second leading cause. People take NSAIDs like candy, and the biggest cause of GI bleeds is they're coming into the GI lab, and we talk to them, and they've either been taking aspirin or Aleve or ibuprofen, way more than what it is recommended. And stress ulcer prophylaxis. We still do have some patients that can get ulcers from stress. It's just not nearly as common as we used to think it was. And the PPIs, it stands for proton pump inhibitor. So Carafate is a drug that is a mucosal protectant for ulcerations and PUD. And this one either comes in a slurry form or it comes in a big tablet that has to be heated up, and you put it in a cup and then you melt it in warm water, or it dissolves in the warm water into a slurry. And that's how you have to give it to patients. The way that it actually works is it sticks to the ulcer, and so patients need to take it on an empty stomach, and they need to take it 2 hours before meals or after, and about 1 hour before bedtime, and then they need to take it 2 hours before or after other medications because it's sticking to that ulcer. Misoprostol or Cytotec is a prostaglandin. We actually have used it off-label for ripening the cervix in OB patients, but that's another story. We use it for gastric ulcers or for patients who have taken too many NSAIDs because it is this mucoprotectant and it produces a bunch of mucus to protect the ulcer. So that is what that drug is used for. Simethicone or Milacone is an anti-flatulent, and so we often use this. You see Milacone drops for babies who have they're screaming and crying because their bellies hurt. They have colic. So here's some examples. Dorothy's complaining that calcium carbonate tablets, which is another term for Tums, that she's taking for antacid therapy taste awful. She asks why she must chew them and if she could just swallow them whole. Well, they are not going to work as well for her if she swallows them whole. They have to be chewed thoroughly for the best and fastest effect. That is what is making them break down and metabolize into her gut. The Wicked Witch is taking a combination product for heartburn. She asks why these drugs have more than one type of antacid in them. Can I just take a small dose of milk of magnesia? Well, the reason that Mylanta or some of these other antacids might have magnesium and aluminum in them is to prevent a person from having diarrhea, because milk of magnesia can be given to a patient who is constipated because it will help them to have a bowel movement. So if she takes milk of magnesia, it could give her diarrhea because magnesium causes diarrhea. Other drugs such as aluminum are often mixed with magnesium to counteract the diarrhea that the magnesium may cause. The Cowardly Lion has renal insufficiency and chronic dyspepsia. What antacids should be avoided in this patient and why? Well, he doesn't need calcium and no magnesium. So no milk of magnesium because of excretion impairment from kidney dysfunction, and we also have to be really careful with the calcium containing products too. Glinda the Good Witch has been diagnosed with PUD, and tests show that the presence of H. pylori in the gastric tissue obtained through endoscopy. She has prescriptions for omeprazolol and an antibiotic. She questioned you about the reason she has to take 2 medications. Well, once we test somebody in endoscopy and they come back positive for H. pylori, and you can read this section in your text, but there are several different cocktails they could be on, and this is dependent on the physician, but they are usually on several antibiotics. They may also be on Pepto-Bismol, and they will definitely be on a PPI. So we'll give them an antibiotic to destroy the H. pylori, and that may be, they could be on the antibiotic for 6 to 8 weeks. My mom was on an antibiotic for 2 months, so it really is physician dependent. The PPI, of course, heals the peptic ulcer, and then they usually will go ahead and also put them on Pepto-Bismol as an anti-inflammatory process. The Munchkin Mare is in for follow-up visit after receiving a prescription for omeprazolol, which is a PPI. He tells you that his symptoms have not changed. When you ask about how he's taking his medication, he takes it just after eating, and he likes to open the capsule because he hates taking pills. Well, that's not going to work for him. The granules in the capsule should not be chewed or crushed because that inactivates the medication. TB is a 48-year-old patient and returns to the clinic today with complaints that the medications he's taking for his recently diagnosed gastritis and small gastric ulcer are not working. In reviewing the medications, the nurse identifies that TB is taking Maalox, okay, that's an antacid, sulcarafate, Famotidine is Pepsid, and the combination medication of bismuth subsulcilate, which is Pepto-Bismol, tetracycline, an antibiotic, and metronidazole, which is Flagyl, which is another antibiotic. TB says that he is ready to stop taking all of his medications. Well, this is not good because in reading all of that, it sounds like he has H. pylori. The nurse asks TB about his dosing schedule. TB tells the nurse he is taking everything at once, 30 minutes before each meal and before he goes to bed. Well, he cannot be taking that right because we know the Carafate needs to be taken on an empty stomach and 2 hours before or after the rest of the medications. So what the nurse needs to know and what the patient needs to know. What will the nurse teach TB regarding when to take Maalox? Well, we need to take Maalox at least 1 to 2 hours after the other medications because if taken together, it's going to make the other medications less effective. And remember that Maalox is just an acid neutralizer. And it's liquid. And it does work, within 30 minutes. TB asks the nurse why there are antibiotics in his medication regimen. How will the nurse respond? Well, this is to attack the H. pylori bacteria. And if we don't do that, they need to be aware that if we don't treat that completely, that could later lead to stomach cancer. I think patients will be more compliant if they understand why they're on this medication and why they need to finish it. One of the patients is being treated for an ulcer with sulcarafate or carafate slurry. How will the nurse describe how this medication works? It protects the mucosal lining of the stomach for stress ulcers, and it's used for peptic ulcer disease. It binds to the epidermal growth factor, and it talks about how it stimulates prostaglandin molecules and serves as a mucoprotective function. Okay, I would never tell that to a patient. I always tell the patient that it sticks to your ulcer because that's much easier to understand. And in theory, that's really what it does. What will the nurse tell the patient about dosing? The slurry is made by mixing a tablet in a small amount of water before taking it. We take it on an empty stomach. It's taken an hour before meals and at bedtime, but what ends up happening when they're on other medications is it acts locally, not systemically, and we have to take it 2 hours ahead. The other drugs have to be taken 2 hours ahead of Carafate, so things kind of change on their schedule because of that. Diarrhea. 5 to 8 million deaths per year in infants and small children are related because of diarrhea. Because if you think of body mass, people can get dehydrated rather quickly, and that can lead to death. So it can last from 3 days to 2 weeks, and chronic diarrhea can last from 3 to 4 weeks and is associated with lots of stools, fever, nausea, vomiting, weight reduction, weakness, as you can imagine. We have to try and figure out the cause and eliminate the cause. It can be caused by drugs, bacteria, viruses, nutritional deficiencies, protozoas. Chronic diarrhea can be caused from cancers, can be caused from AIDS, diabetes, hyperthyroidism, Addison's disease, and the IBS syndromes. Treatment is aimed at stopping stool frequency, alleviating belly cramps, getting the patient some fluids and electrolytes, and preventing weight loss and nutritional deficiencies and malabsorption. And we often have to give the replacement IV fluids and electrolytes. There are some antidiarrheal drugs, and based on the specific mechanism and action, we divide them into the absorbents, the anti-motility drugs, which are anticholinergics and opiates. There's also some probiotics known as the intestinal flora modifiers and bacterial replacement drugs. On the flip side, we use laxatives for the treatment of constipation if we have to. It is a symptom, not a disease, and this is when stool slows down through the colon, rectum, or both, and it can be caused from a variety of diseases or drugs. like opiates, or just, slowing down from immobility. Laxatives are often misused over-the-counter medications. Long-term and inappropriate use of laxatives you can get dependent on them, and it can produce actual damage to the bowel or lead to previously non-existent intestinal problems. So we prefer the use of bulk forming type laxatives, like your fiber laxatives, for long-term periods. Based on the mechanism of action, we've got 5 major groups. We've got bulk forming, and those are listed on the OK. We can do those. The emollients, the hyperosmotics, the saline, and the stimulant laxatives are not for long-term use. They act by affecting fecal consistency, increasing fecal movement through the colon, and facilitating defecation through the rectum. Irritable bowel syndrome, known as IBS, is a chronic intestinal discomfort characterized by cramps, diarrhea, or constipation. Tegaseroid, or Zelnorm, is a serotonin 5-HT4 receptor agonist and is approved for treatment of IBS with constipation and chronic idiopathic constipation in women younger than 55 years of age who have had no alternative therapy that has worked. Another one is lubiprostone, or Amicia, and it's a chloride channel activator that is indicated for the treatment of chronic idiopathic constipation and IBS with constipation in women 18 years of age and older. Aldosterone, or Lotranex, is a selective serotonin 5-HT3 receptor agonist that is indicated for the treatment of severe chronic diarrhea, predominant IBS, in women who have failed conventional therapy. What I will say is that the pattern with all of the IBS medications is that if they aren't working, they aren't, the risk is not enough for the patient to be on them, and so the physicians will not keep the patients on them, because the big risk for the IBS drugs is bowel rupture. So if the patient starts having severe abdominal pain with these, then they need to report it. That is the biggest risk with the IBS drugs, and so that is what nurses are looking for, is to make sure that the patients don't have ischemic colon or a bowel rupture. S, age 18 months, has had diarrhea and vomiting for 2 days. His mother is worried that he is not getting better. And that's a baby, and they can get dehydrated really quickly. The mother should take S for medical care as soon as possible because of the risk of severe dehydration. T has been taking bismuth subsalicylate, which is Pepto-Bismol, for diarrhea, and is alarmed because his stools have turned black. Well, that is actually common, and it's okay. That's an expected adverse effect of this drug. It also can cause the gums to turn a funny color too, like a blue color. F has been on antibiotic therapy for 1 week and has developed diarrhea as one of the adverse effects. She still needs to continue the antibiotic therapy, and the physicians suggest Lactobacillus acidophilus, or Lactonex. This is a probiotic. This is an intestinal flora modifier that works by replenishing the bacteria, or the good flora, and restores the balance of normal flora and suppresses the growth of diarrhea-causing bacteria. So this would be kind of like what we have talked about before with patients on antibiotics. This could prevent, getting that good flora out of our gut. B's father calls your office and asks if it would be okay to use Pepto-Bismol for her diarrhea, and B is 11. Well, there is a component in Pepto-Bismol that has salicylate in it, and we have discussed before that that could lead to Reye's syndrome. And so if the patient has had any kind of a recent flu-like virus or illness, that's not a great idea. So need to rule out the presence of viral illness because Reye's syndrome in this age group should not be taken. R has had problems with constipation and decides to take Metamucil. This is a bulk forming. He is also taking digoxin and warfarin for other health problems. Well, here is a pattern that I have told you guys about. That's never a good idea. The Valium may cause decreased absorption of both drugs, thus alternating their effectiveness. So, patients on digoxin and warfarin really need to talk to their physicians about taking anything else because it seems that they interact with everything. 79-year-old patient newly admitted to your unit has just had a fecal impaction removed. That can be very painful. And his daughter says he often has hard stools. What drug is most commonly used for this problem? We're going to use mineral oil, and we hope not to use it all the time because we don't want to get the patient addicted to an emollient, but we're going to use that for a bit to get the patient to have softer stools. G, age 5, has constipation. What could his mother give to help him? We've just got a 5-year-old. So we could do glycerin suppositories. Case of IBS. So we've got JS, a 20-year-old college student and daughter of Glinda the Good Witch, has been having an ongoing occurrence of diarrhea, intestinal cramping, and occasional constipation. She has tried many over-the-counter medications to treat the diarrhea with little success. She's lost 15 pounds and is very tired. She goes to see the gastroenterologist and is diagnosed with IBS. The GI doc prescribes allosterone or Lotrinex for JS. What side effect of the drug will the nurse include in the patient teaching? We're going to tell her to contact the physician immediately if she has bloody diarrhea, severe abdominal pain, because this drug can lead to ischemic colitis. Allosterone can also lead to severe constipation, which she should report to the physician. Because of the possibility of significant and life-threatening side effects, the patient must document any abnormal responses and know what to report immediately. She wants to know when she will start to feel better. It's not a magic bullet. We need to tell her that she would start to feel better in about 4 weeks. If she doesn't, she's going to be taken off this drug because it's risky. If she doesn't understand how long the drug will take to work, she may cease the medication before it has even had a chance to work. Alright, chapter 52 talks about puking. Of course, you might remember back from patho that nausea and vomiting involves the CTZ zone, or the chemoreceptor trigger zone. These signals alert those areas of the brain to the existence of nauseating substances, or noxious stimuli. And when the CTZ and vomiting center are stimulated, they initiate the events that trigger the vomiting reflex, or the gag reflex. Anticholinergics work by blocking acetylcholine receptors in the vestibular nuclei and reticular formation, and that prevents the areas in the brain from being activated by nauseous stimuli. And anticholinergics also dry the GI secretions, reduce smooth muscle spasms, both of which are helpful in reducing nausea and vomiting. Antihistamines can work by blocking H1 receptors, producing the same effects as the anticholinergics. Antidopaminergics, or antiemetics, block dopamine receptors in the CTZ zone and may also block acetylcholine receptors. Prokinetic drugs also block dopamine receptors in the CTZ zone. So we've got some choices. Serotonin blockers work on blocking serotonin receptors located in the GI tract, CTZ, and vomiting center. So the serotonin blocking drugs, granisteride, I'm having trouble saying that, but granistrone and ondansetron are the most commonly used for the prevention of chemotherapy-induced nausea and vomiting. THC, or tetrahydrocannabinol, THC, is the major psychoactive substance in marijuana, so we do have a non-intoxicating dose called drobenol or marinol, used as an antiemetic because of the drug's inhibitory effects on the thalamus and cerebral cortex. So there is a pill form that we can give patients that does increase appetite and helps with nausea and vomiting. And we do give it. And let's see, granistrone and ondansetron, that's Zofran and Chytrel. And we use those very frequently. The ultimate goal of antiemetic therapy is to prevent fluid and electrolyte disturbances and minimize deterioration of the patient's nutritional status. In oncology, if we're giving the Zofran and the Chytrel, we'll also give it with Solumedrol IV push because that antagonizes the drug's effects and makes it work better. So 6 separate groups of antiemetics in this chapter: the anticholinergics, the antihistamines, the antidopaminergics, the prokinetics, the serotonin blockers, and the tetrahydrocannabinoids. I just want to say THC. And then we have actually learned a lot about herbal products in oncology specifically, and alternative medicine for that matter, and different pressure points for nausea and vomiting too. But ginger works quite well, so does peppermint, and we will give patients ginger lollipops during their chemotherapy. And we've tried about everything, and it's been studied, and it actually does work for some patients. It doesn't work for all patients, but it can be used for nausea and vomiting, for chemotherapy, morning sickness, and motion sickness. Can cause nausea and vomiting, or for some people. So you're going to have to, it's one of those things you've got to try. It can increase bleeding with anticoagulants, so you would not want to give ginger to someone who was on Coumadin or warfarin or heparin. And it can increase absorption of oral medications. All right. R, age 72, has motion sickness and is planning a flight to California. He is prescribed scopolamine, or transderm scopolamine, which you might remember is that little patch that you can put behind the ear that is an anticholinergic. Be sure to provide instructions on how to apply the patch and adverse effects. Okay, well, this lasts for 72 hours, and they want to put it behind the ear, and it is going to cause the patient to be dry, can help with nausea and vomiting and motion sickness, and it also dries up secretions. G, age 48, experiences vertigo. She has a prescription for meclizine or Antivert. See Table 52.4 regarding the adverse effects such as dizziness, drowsiness, and blurred vision. The big thing here is that it's a safety issue, so we want to make sure that the patient, which shouldn't be driving anyway because she has vertigo, but she needs to know that she should not be driving or operating heavy equipment while on this drug. J, age 51, has intractable vomiting because of chemotherapy, and the physician is considering Drobenol, which is Marinol. However, the patient's upset about the possibility of getting high when he finds out the source of the drug. Well, we need to make sure that the patient knows that there is not the level of intoxicating THC in the pill form of this drug, and it is non-habit forming. M, age 42, is undergoing chemotherapy treatments and receives ondansetron, known as Zofran, as needed. emphasized the need to administer the drug 30 to 60 minutes ahead of the chemotherapy and on a regular schedule during the chemotherapy. It isn't something that you can give like 10 minutes ahead of time and think that that's gonna fly. They need to have it, at least 30 to 60 minutes before they receive their chemotherapy in order for it to work for them. Auntie Em and Uncle Henry will be going on her first cruise next week. She is worried that her motion sickness will cause her to become nauseated on the ship. She is seeing you today for some suggestions on how to handle her motion sickness. The practitioner prescribes scopolamine transdermal patches. What is the mechanism of action of scopolamine? Well, we know that this is an anticholinergic already. And it works by blocking the acetylcholine to the cholinergic receptors in the vestibular nuclei, which are located in the area of the brain that controls balance. And when acetylcholine is prevented from binding to these receptors, nausea-inducing signals originating in this area cannot be transmitted to the CTZ zone. Nurses must understand the role of the medication in the treatment of a disease and disorder. What patient teaching will the nurse provide about the use of the patches? Well, we're going to tell her that it lasts for 72 hours and it should be replaced at that time in a different area behind the ear. The patch should be placed over a non-hairy area without scars or raised areas, and the area behind the ear needs to be cleansed and dry before the patch is applied. And if the patch becomes dislodged, the residual drug must be washed off and a new patch applied. Patches must have direct contact with the skin to be effective, and the patient must understand that each patch has 3-day duration of action, so does not need to be replaced too early or used too long. What side effects should Auntie Em expect? She could have some dizziness and sleepiness, and she should avoid tasks that require a lot of mental clarity, not driving any heavy equipment. She shouldn't be being the captain of the cruise ship. When patients understand the possibility of side effects, they'll avoid activities that could put them at risk for injury or increased side effects. Munchkin with hyperemesis gravideum. DV is 6 weeks pregnant and is experiencing unrelenting nausea and vomiting, causing significant dehydration. And I have taken care of patients that have this, and it's horrible. She's unable to keep any food down and is admitted for management of hyperemesis gravideum. She is hypotensive and tachycardic upon admission. We not only have to give these patients fluids and try to get their vomiting controlled, they have a lot of guilt because they are fearful that they are starving their baby. What medical management is indicated for DV? IV fluids will be given for electrolyte nutrition and volume replacement, and she will be prescribed ondansetron or Zofran for severe nausea and vomiting. The IV fluid replacement will rehydrate her, and she will have some increased intravascular volume, so she will not go into shock. And it sounded like she was already having some collapse if she was hypotensive, and that will cause the blood pressure to rise, improve her cardiac output, and bring the heart rate down to normal rate. Zofran is used for the treatment of hyperemesis gravideum associated with pregnancy, and then after we get her calmed down, not only is it available in the injectable form, we can give it to her in these oral disintegrating tablets that she can put under her tongue or in her mouth, and we can give her doses up to 8 milligrams, and that can be given IV push over 2 to 5 minutes. What would the nurse include in patient education regarding treatment for this disease? She can be on bed rest, and when she gets up, she needs to dangle to prevent orthostatic hypotension. There are treatments such as acupressure and ginger and peppermint and essential oils to decrease nausea, bed rest for comfort, and she needs to decrease workload on the heart. These acupressure and acupressure points can help to reduce nausea. There's something called C-bands that can help with acupressure. The ginger and peppermint and essential oils and herbs help with nausea and vomiting, and then foods will be resumed as tolerated, and the patient needs to start kind of keeping a diary as to what foods may not be something that they want to be around and what foods work for them. Now, chapter 53 talks about important vitamins and minerals. We know that we've got to use our carbs, fats, and proteins appropriately, and ingesting food maintains adequate stores of essential vitamins and minerals, and we just need nutrition, right? Well, these can also affect absorption of our medications too, and various illnesses can cause acute or chronic deficiencies of vitamins, minerals, electrolytes, and fluids. And then we have to do replacement therapy. Excessive loss of vitamins and minerals may be the result of poor dietary intake or the inability to swallow because we have mucotitis in our mouth from oral ulcers after chemotherapy or radiation, or you can have mental disorders such as anorexia nervosa, or poor dietary absorption from GI malabsorption syndromes. There is something called B12 deficiency from pernicious anemia. There are drug and alcohol abuse deficiencies from poor nutrition that require supplementation. So the standard or dietary reference intakes, DRIs, represent optimal nutritional amounts for good health. The U.S. requires detailed packaged food product information, and that helps us. And so we try to meet those. Vitamins are classified as either fat soluble or water soluble. The water soluble can be dissolved in water and excreted in the urine, and the fat soluble are dissolved in fat and tend to be stored longer in the liver and fatty tissues. So the water soluble vitamins are B complex group and C, and cannot be stored in the body in large amounts. Daily intake is required to prevent the development of deficiencies. The fat-soluble vitamins A, D, E, and K do not need to be taken daily. So A, D, E, and K are present in plant and animal foods, primarily stored in the liver, exhibit slow metabolism or breakdown, and are excreted via the feces. They can reach toxic levels if taken in excessive amounts. Vitamin A helps with vision, so if somebody doesn't get enough vitamin A, we are told that they can have something called rhodospin because of major retinal pigments for vitamin A. So we try to always tell people to get enough vitamin A in their diet. It's best to get this in your diet. Vitamin D is the sunshine vitamin because this one is responsible for calcium and phosphorus in the body, and vitamin D is the one that is synthesized by the skin. 4 biologically active chemicals called tocopherols, alpha, beta, gamma, and delta, make up vitamin E compounds. And this comes from plant and animal sources. If someone gets a lot of vitamin E and they are taking anticoagulants, that can increase the effectiveness of the anticoagulants and make them bleed. So that is something to be careful with. Vitamin K is essential for clotting factors, which take place in the liver. Vitamin K dependent blood coagulation factors are 2, 7, 9, and 10, and other names are factor 2, which is prothrombin, factor 7, proconvertin, factor 9, Christmas factor, and factor 10, Stewart prolifactor. The normal serum levels are listed there. I'm not asking you to remember those, but you do need to know that that vitamin K is essential for blood coagulation. So A, D, E, and K are our fat-soluble vitamins. D is the sunshine vitamin, and D is become quite popular. There's a lot of studies being done that patients have vitamin D deficiencies, and it's led to autoimmune disorders and heart disease, and so there are a lot of physicians recommending vitamin D supplementation because maybe we're not getting enough sun. The water solubles are B1, which is thiamine. Thiamine deficiency can be related to Wernicke's encephalopathy, which is common with alcoholism, and it's being described in your book as a common finding with brain lesions. And so we definitely will, if someone comes in to the hospital and we know that they're an alcoholic, we will be giving them thiamine or B1. We will even put it in their IV bag. Vitamin deficiency of B1 from poor diet, hyperthyroidism, liver disease if they already have cirrhosis, alcoholism, malabsorption, pregnancy, and breastfeeding can occur. Niacin is vitamin B3, and it is indicated for the prevention and treatment of pellagra, which is a deficiency of B3 that is usually caused by malabsorption disease. We also can use niacin to treat hyperlipidemia, and it's beneficial for peripheral vascular disease. B6 deficiency can lead to a type of anemia that causes neurological disturbances, or dermatitis or cheilosis around the sides of the mouth, and it can result in convulsions in neonates and infants, and glossitis and stomatitis in the mouth. Pyroxidine is the other name for vitamin B6. It also affects the nerves, the skin, the mucous membranes. Inadequate intake or poor absorption can lead to the development of these conditions. B6 deficiency may also occur as a result of alcoholism. So again, B1 and B6 may be added to a bag, an IV bag for patients that come in that are alcoholics. So patients with cirrhosis, hyperthyroidism, malabsorption syndromes, and heart failure. It can also be induced by certain drugs like INH for TB and hydralazine. So those are some water solubles. Remember that B1 and B6 are often given to patients who are suffering from alcoholism. B12 is a water-soluble B-complex vitamin given for patients who have pernicious anemia, and it is B12 deficiency results in GI lesions and can cause neurologic changes in the central nervous system and megablastic anemia. It's the major cause of malabsorption, and it can be caused by poor diet, chronic alcoholism, and chronic hemorrhage, but it is the most common cause is pernicious anemia, which is where patients don't have the factor in their body to be able to make enough. So we have to give them shots every month of B12. Otherwise, if it's not treated, they'll have megablastic anemia and they'll have irreversible neurologic damage. Vitamin C, or ascorbic acid, can be given in a lot of different situations. And prolonged ascorbic acid deficiency results in scurvy. The sailors found that out. And that's causes weakness, edema, gingivitis, bleeding gums, loss of teeth, anemia, subcutaneous hemorrhages, bone lesions, delayed healing of the soft tissues. So we often give people vitamin C when we're doing wound healing, and hardening of leg muscles. It's required for maintenance of bone, teeth, and capillaries, and folic acid metabolism, and it's essential for erythropoiesis. It enhances the absorption of iron, so if we're giving someone liquid iron, we often will see if we can mix that with vitamin C, and it's helps with the synthesis of lipids, proteins, and steroids. It's also been shown to aid in cellular respiration and resistance to infection. But we can get vitaminosis from vitamin C. And people, everybody knows that vitamin C helps with flus and colds and that kind of thing too. And so if someone takes too much vitamin C, they can actually get crystallate stones, oxalate stones. So you can get kidney stones from having too much vitamin C. Calcium deficiency results in hypocalcemia and can affect bodily functions. And so we need vitamin D to facilitate absorption. And so if we have hypoparathyroidism, the parathyroids are right next to the thyroid, and malabsorption syndrome in older individuals, we can get calcium deficiency related disorders. Of course, there's osteomalacia, there's rickets, osteoporosis, hypoparathyroidism. Those often get nicked in surgery if somebody has their thyroid removed. And renal dysfunction, giving you your normal serum levels there. Calcium is essential for normal function of nervous, musculoskeletal. It's important for the heart. So we definitely got to have that mineral. Magnesium is another principal cation present in intracellular fluid, and it's essential for energy metabolism. If we have hypomagnesemia, it's usually caused by malabsorption in the presence of high calcium intake. This can happen in alcoholism or long-term IV feedings, diuretic use, metabolic disorders, including hyperthyroidism and diabetic ketoacidosis. Symptoms associated with hypomagnesemia include cardiovascular disturbances, so we might have some dysrhythmias happening, neuromuscular impairment, and mental disturbances. Dietary intake from vegetables and different foods usually prevent magnesium deficiencies, and so usually we get our minerals and a lot of our vitamins from proper diet. Phosphorus is widely distributed in foods, so dietary deficiency is rare. Deficiency states are primarily caused by malabsorption diseases, extensive diarrhea or vomiting, hyperthyroidism, hepatic disease, and long-term use of aluminum or calcium antacids. So, AF is a 35-year-old patient who underwent a partial gastrectomy because of a large gastric ulcer. She is seen by a physician today for follow-up. She's healing well but complains of significant tiredness and numbness of the fingers, and her tongue looks different. The physician suspects pernicious anemia and orders a complete blood cell count and a vitamin B serum level. AF's B12 level is 88, and the CBC shows that she is anemic. Vitamin B12 replacement is ordered. Her tongue looks different because she's got glossitis, or a very glossy tongue. What does the nurse suspect is the most likely cause of the pernicious anemia? It's because she's now missing this portion of her stomach, and so she lost the intrinsic factor needed for absorption of vitamin B12, and the nurse understands that the cause and the pathophysiology of the disorder affecting the patient prepares us to teach her better about the required therapy that she's going to need for the rest of her life. What is the most likely route we will be using to administer B12? IM. We're going to give it intramuscularly. We can do intranasal. Administration of oral vitamin B12 should be questioned because with no intrinsic factor, it's not going to be absorbed. What patient teaching will the nurse provide regarding the adverse effects of vitamin B12 replacement? Well, we would tell her it could include heart failure, vascular thrombosis, pulmonary edema, flushing, optic nerve atrophy, diarrhea, pruritus, rash, pain, and injection sites, probably the one I'd be honing in on, and hypokalemia. In addition, the nurse will tell the patient the treatment will be needed for life. Honestly, I'm not familiar with most of those other side effects, and because I am familiar with the side effect of neurological disturbances if they don't get their B12, I would be focusing on telling them that, pain at the injection site, and they, if they had the pulmonary edema, we would want to, give them some teaching on that, and heart failure, since those are some of the ones that stick out to me. Patients need to have a thorough understanding of the side effects and report them to the physician. Wicked Witch is being treated for osteoporosis with calcium and vitamin D in an attempt to slow the progression. She asks the nurse about the relationship of vitamin D and calcium absorption. What teaching will the nurse provide? Vitamin D, either from foods or supplements, helps the body absorb calcium and regulates the levels of calcium in the bones. It is found in fish, such as salmon and canned sardines, and the body can form it naturally with the help of the sun. The efficient absorption of calcium requires adequate amounts of vitamin D. She asks why she developed osteoporosis. What risk factors does the nurse inquire about? Calcium deficiency most likely is related to her white race, small frame, sedentary lifestyle since Dorothy returned to Kansas. Causes of calcium deficiency include inadequate calcium intake or insufficient vitamin D to facilitate absorption, so she wasn't getting out in the sun enough, hypoparathyroidism and malabsorption syndrome, especially in older individuals. Calcium deficiency related disorders include infantile rickets, adult osteomalacia, muscle cramps, osteoporosis, especially in postmenopausal women, which of course the Wicked Witch would be, hypoparathyroidism, and renal dysfunction. Get well soon, Dorothy.